Before you start, have you already started?
Oh, I can stop it really easy.
I think I am sharing our guidelines for testing. Can you all see it?
Yes.
Yes.
Good. Okay. Okay. Excellent. And I also believe that Chuck sent you out your own copies of it. So you should have it if you wanted to print it off to go through in detail or make notes on it, whatever you want to do. Maybe you've got your tablet and you can make notes right on it. Sometimes that helps.
Cheryl and Christy would be the ones that send that out. Do you all already have it? Cheryl, do you know if you guys been sent out to everyone?
I don't believe we have. I
haven't sent
out.
anything today.
No.
Okay. Well, Chuck can send it while we're talking through this. Okay.
I'll get it over, Cheryl, and you can send it on.
Thank you.
Sounds good.
All right. So isn't that pretty? Wow. Looks like a flower, doesn't it? Unfortunately, it's what's killing us. So what we're going to start with, this is the AD document that we have. And one of the things that we want our clinicians right up front to have at their fingertips is how to kind of tell when a person presents with any type of symptoms, kind of things that can differentiate it. And I can tell you as a clinician, particularly looking for COVID, I've had patients who came in and had real obvious symptoms of COVID. I've had other patients come in and it's not so obvious. And when I test them, because I'm a little liberal with testing right now, they come back positive sometimes. And so a few of the things, and you're going to see some data on this as we go through, but one of the things that's a real differentiator is that loss of taste or smell. And I think you all know that. That's something we've talked about a lot. But we've really never seen that in any common viruses before. And in allergies, while people do get stuffy and may talk about that they can't smell, it's because their nose are clogged. And so in general, it's a real differentiator for us when we see that loss of taste or smell. Shortness of breath. There are some patients with influenza that get bad. They're usually older. As we've talked about all through this COVID virus, we've always known that patients sometimes, certain years particularly, back in 2009 was one of them, can get a bad case of influenza and wound up in the hospital. But in general, most years, pretty mild. So it's rare on that shortness of breath. So, same thing with a cold. I don't think I've ever seen, other than a patient with COPD, wind up with a cold that got very bad. And allergies are not going to, in general, be short of breath. Cough, it's common in most of those, and even in allergies, it can be common. Fatigue, it happens with most viruses. People will feel more fatigue. Sometimes they don't sleep as well, and that's why sometimes allergies, you're going to be more fatigued at that point. Fevers and chills, often with any type of virus. Colds, though, we don't usually see those real high fevers, but the influenza and the COVID we do, and you're not going to see that with allergies. Myalgias, meaning the muscles ache and hurt. Sometimes we get that with COVID, but 40% of our patients who have COVID don't know they have it, so they might not have some of these symptoms. Influenza, very common, and with colds, allergies don't really get myalgias. This is another one that has been a differentiator. It seems like COVID does have more GI and diarrhea issues. You probably saw some of the reports early on that, hey, we've got a rash of people having diarrhea right now. Not every patient gets it, but that is one of the things that has been positive. Influenza, you can get some GI upset. Colds, no, and allergies, no. And then headache, I have had people really complain to me who have had COVID with headaches. So that's, and then influenza, that's a very common thing. Sore throat, not as much as you'd think. Usually with colds and even with allergies, you can get a sore throat. I used to suffer from allergies and thought I was getting my seasonal cold until I figured out it was allergies. And it was really, I'd get a really bad sore throat in the back of the throat. Sneezing, it's rare. Colds, it's pretty common. Stuffy nose, again, rare. That's kind of interesting that you lose your smell, but not have necessarily a stuffy nose at times. And so one of the things that we're talking about is how do we decide who we're going to test? And this is one of the things that Jewel has really been helpful on helping me understand. We really have to have some rules in place about who we are going to test and who we're not, particularly because we've got a research protocol here. So we are going to ask our clinicians to ask these 3 questions when patients call or come in. Have you been in contact with someone who has a positive COVID-19 test with or without symptoms when neither wore masks and you were closer than 6 feet apart for at least 15 minutes? So there's a good chance those people will be transmitting, right? Number 2, have you been in contact to someone with fever, cough, muscle aches, fatigue, or other symptoms of COVID who has not been tested? And then finally, do you have or have you had a fever, cough, loss of smell or taste, body aches, or shortness of breath? And if yes to any of those, we're going to want them to treat them as contagious, isolate them, use proper PPE when seeing the patient. In other words, making sure the nurses, the clinicians, everybody gowns and masks, preferably taking care of them outside of the clinic in their car, and make sure they get tested. Okay. I'm going to stop real quick and just see so far, are there any questions from any of the practice facilitators? Do you need clarification or you want to ask something about?
Dr. Beasley, this is Courtney. I had a question on the testing part of it. Is there not like a time frame that they need to kind of go by as far as like how long they've been symptomatic?
That's a good question, Courtney. In general, you can imagine how a person would have a curve starting up. Their viral load would be pretty high, and then it tapers over the course of a week or 10 days that they have the illness. So could you potentially miss it early? Yes, you could. They could just be starting to get some symptoms and not have as much viral load at that point. Could I potentially miss it late? Yes, I could on that end as well. But in general, it's a pretty sensitive test, and overall, it does a good job of catching it throughout that time overall. Does that help?
Sure does. I just wanted to make sure we had that information to share with our clinics as well. So Thank you.
Anybody else? Let's move on then. We're going to talk a little bit about testing for COVID when the upper respiratory symptoms and cough are positive. We're talking to our clinics about using only FDA approved tests. We're going to talk to them about a nucleic acid or antigen SARS-CoV-2 viral tests on samples collected with nasal swabs, and then use either point of care rapid test. And we're going to talk about the one we're going to use in our clinics that have joined us in a couple minutes here. The rapid tests, the results are available less than an hour, or tests that are sent to a laboratory and may take several days. Okay. And we're going to recommend do not test the same individual more than once in a 24-hour period. All right. Otherwise, we're kind of wasting resources really then. And then the big exclamation point, do not use antibody tests to diagnose acute infection. So most of this is all going to be done through the nose. There are some tests that can be done in the mouth at the back of the pharynx. But the one that the exclamation point is talking about is actually drawing blood from the arm, and that you could look for antibodies. Well, that's not used for acute infections, or in other words, an infection that's going on right now. That's used to check and see if someone has already had COVID, and some of these people didn't even know they had COVID. So that's a good reason to use that that type of test, is trying to find out, did they have COVID? But in general, we're only going to be asking them to use these viral tests and our rapid tests in general. Let's talk a little bit about personal protective equipment, PPE. And so we're going to teach our folks that if you're dealing with a patient who's a good chance they might have COVID and we're going to test them, we're going to deal with them in any way, make sure you're prepared with proper PPE, ensuring the correct gown size, that they would perform hand hygiene using hand sanitizer. They would put on the isolation gown, tying all the ties on the gown so that their clothes are all protected. They would put on a NIOSH approved N95 filtering respirator, fitting the nose piece to the nose with both hands without bending or tenting, and cover both the mouth and the nose, not wearing it down here, right? And then placing the respirator straps on the crown of the head. So the straps go right up here and at the base of the neck, so back here. So one goes up and one goes down to the back of the neck. And then putting on face shield or goggles, because it can be spread through respiratory droplet transmission, and you could get some in your eye and get it that way. And then putting on gloves to cover up to the cuff of the gowns. So you want it over the gown's cuffs. So we see the person there who's all prepared. They've got their face shield or goggles on. They've got their N95 respirator. And when respirators are not available, using the best available alternative, like any type of face mask at least, but preferably an N95 if you're going to go out and test someone in their car. The pair of clean gloves that are doesn't have to be sterile gloves. It's not a sterile procedure. And the isolation gown you see there. So physical distancing, face masks, and eye protection prevent person-to-person transmission of SARS-CoV-2 and COVID-19. And that is a rule that we want to hammer home with all of our people and our patients anytime we have the chance, that these things work, okay? I'm going to stop again, just see if anybody has questions about the gowning and gloves and the face mask. All right, let's move on then. And please don't hesitate to stop me, because this is for you all. I want to make sure you feel comfortable being able to help the clinics learn this and teach this to them. So nasal swab specimen collection. So we're going to be talking about, you'll hear the BD, that's Beta Delta, BD Veritor system. Doesn't stand for Beta Delta. I'm just saying that those are the letters, BD Veritor system for SARS-CoV-2. And it has a nice picture here, and this is a nasal swab. So remember, when people are going for the viral test, they are going way back down, all the way, you know, when you look at the pictures, it goes all the way, seems like it's almost to the patient's brain. And this is not one of those. The BD Veritor is one that goes up into the nares, like you would pick your nose, and then 1 inch from the edge of the nostril, up to 1 inch from the edge of the nostril. They're going to roll that swab 5 times, so just kind of twisting it 5 times along the mucosa inside the nostril to ensure that both the mucus and the cells are collected. And then using the same swab, not a second one, repeating the process for the other nostril. So we're going to do it on both sides with the same swab to ensure that the adequate sample is collected from both nasal cavities. And then they're going to withdraw the swab from the nasal cavity, and it's now ready for processing using the BD Veritor system SARS-CoV-2 kit. Let me stop right there and see if anybody has any questions about the procedure. Pretty
Dr.
simple.
Beasley?
Yeah, please go ahead.
I don't really technically have a question about this procedure, but on Friday I had to have my daughter tested because she had to come home. And so I don't know what test they were using, but I can tell you that they did not do both nostrils and they did not swirl it around 5 times. So is that the same thing with most kits or most tests, or is this just specific to this test?
Well, thank you for asking. I would say that on the viral test where they go way back deep, I have not heard of them using on both sides. For this BD Veritor that we're doing, it is recommended that we do it that way. So we'll be teaching our clinics that way. Tim, do you have more data, or if you're still on there, do you have more data about both sides for other types of kits or tests?
You know, I've not looked at a lot of the other kits in terms of exactly what they suggest, but I would suspect they would suggest the same thing, because the whole idea of swirling around a couple of times as well as doing both nostrils, it just increases the probability that you will pick up the virus on the swab. And if you just stick it in, and there's always a chance that you get a really small amount of cells or mucosa or anything else like that, not enough to be above the sensitivity of the test.
Any other questions before we start this next section? Okay, so you can see here the actual device, what it looks like, the BD Veritor system. And what we have here is this is showing you what when they applied to get this approved, they did a study of 226 people. So we see that here. And they showed comparing the BD Veritor versus the actual viral test that you would be done at the health department or in a higher level lab. They show you what the results of that are. So here are the BD Veritor results, and here is the reference PCR results. So the PCR is actually picking up the actual virus there. So we can see this is the key thing that's kind of interesting here. According to their study of 226 patients, they had 0 that had a what we would call a false positive. Okay, all of their positives were true positives, which means if you get a positive with this test, you can go to the bank on it that you really got the disease. Okay, so that's when we look down here at the positive predictive value, so predicting whether it's positive 100%. So it's a very, very good test. It's not quite 100% on the negative predictive value. In other words, if you get a negative test, we can see right here that a few of them actually did have the disease that had a negative test. But if you get the positive test, all those are true positives. They really have it. Does that make sense? Any questions about how good of a test this is?
I like that we've included that in this guide, because I know that was one of the questions that had popped up whenever I was recruiting. So it's good to see the numbers.
Yeah. Okay, I'm going to move on up. So we're going to talk a little bit about isolation guidelines. So when that's positive, for most persons with COVID-19 illness, isolation and precautions can generally be discontinued 10 days after the symptom onset and the resolution of fever for at least 24 hours. So from the time that you first started having symptoms, if you had it, 10 days later, also that fever has to be gone for at least 24 hours. Okay, but 10 days later, then you can come out of isolation And that fever, that last sentence, without the use of fever reducing medications. In other words, you're not taking ibuprofen or a Tylenol. But we do want these people isolated. That is the key thing on keeping spread out of the community, is isolation. I'm going to talk a little bit more about this issue about a positive test. One of the things to actually diagnose this is that you have an exposure. Maybe you don't have symptoms though, but we know that someone got exposed. You have symptoms, or you have resolved symptoms and a positive test. That's when we say, yep, you definitely have COVID infection. In other words, what this is saying, a single negative COVID-19 test does not rule out infection. From the other standpoint, having a positive test results without any of these, it leaves it kind of iffy. So when patients come to me and say, I want to get tested for COVID, but I don't have any symptoms right now, I don't have a fever, I don't have a sore throat or anything, I just know I just had this kind of vague exposure to someone, or they just kind of want to come in and get tested because it's in the community. I usually tell them I really need there to be some symptoms or a definite exposure, not something vague. But I was around my cousin for 24 hours who tested positive, the next day or something like that. That's when you would really say, yeah, it's a definite exposure. Or some of these resolved symptoms. They've had fevers and a cough, and maybe it's resolved. But there's two issues there. While our BD Veritor really didn't have many false positives, we don't want to push it too hard. The second other is we don't want to use up a lot of our kits on patients that don't really meet the criteria for that. So questions about that?
Dr. Beasley, I have a question.
Go ahead, Heather.
As I have kind of heard through the grapevine, talking to family members and friends, a lot of times if somebody out there, let's say a patient comes in and says, my work's requiring me to get a test, how do the clinics need to approach that? Because if they have no symptoms at that point, that's not what we're trying to do with this test. And so I have a feeling that we're going to come across that at some point.
I think you're right, Heather. I think that'll be a dilemma that our clinicians will be faced with. And I think we'd be naive if we didn't think that they would go ahead and test some of those people, if you know what I mean. We're going to teach them that in general, that's not what that's really for. And maybe they ought to send them to the health department or something like that if the patients determine that they're going to get tested. In general, we do want to keep to what our package insert for this test says we ought to be doing, if that makes sense.
Absolutely.
Other questions? Okay, other questions.
Dr. B, Jennifer posted in the chat.
I know that college athletes are being asked to do that right now before returning to campus and stuff, and that they have to have a negative test in order to actually return and do their sport that they're getting scholarship paid for. Yeah.
And that's not what this test would be for, though, Missy. Thank you. Yeah. And Cheryl, I couldn't hear what you were saying. What was the question?
Jennifer had a question in the chat about how long after the resolved symptoms is the time period to decide whether or not you should test them.
So if someone has had resolved symptoms for a week, would I test them? Or if they've had resolved symptoms for 3 days, would I test them? That's a good question. I don't know how many days I'd let it go. And let's see if Tim has a better answer on that than I do. Tim, if someone's resolved their symptoms, how many days later would a COVID test be useless?
I'd say probably 5 days, but I mean, that's just a wild or wag, it's just a guess.
Yeah.
I don't think we really have a really good feel for that. everybody's kind of bringing up the fact that these will be misused. Now, in terms of the tests that we are, we're providing, those are to be used on uninsured people. And if they're using tests that they buy, aren't getting reimbursed for that, they ultimately can test whatever they want to test. I think there's a couple big issues there, though. One, if they don't have any symptoms or anything else like that, they would probably have a hard time charging the individual's insurance for that based upon CMS guidelines. But if somebody wants to pay out of pocket to have a test done, they could certainly do that. But yeah, everybody knows that people are doing that. They're requiring them before they get on airplane flights and things like that. And for the most part, it just makes people feel better, I guess. It's security theater in some sense, but it's not all that useful, frankly.
Any other questions before we move on? Okay. So thinking about these different types of tests and which type that we're going to be using. So we have the PCR, the nucleic acid test, and the sample is a nasal swab. And remember, that's kind of a deep nasal swab. And the results may take hours. Sometimes it's taken days, particularly in the beginning of this epidemic. We saw it took a long time. It does give us a positive diagnosis. If it's negative, doesn't necessarily rule it out. An antigen test, and that's what we're using when we talk about the BD Veritor, is an antigen test. The BD Veritor wants us to use the nasal, not an oral swab. But there are ones out there of these antigen tests that can be done from the posterior oral pharynx all the way to the back of the throat. The results from that, again, are within minutes, usually. And it can give us a positive diagnosis, as we saw. The negatives, not necessarily rule out as well. And then the antibody test, which again is from the blood, but drawn from your arm. Its results are usually within days, and it does show you might have a current infection if the antibody load is there, and you have symptoms. But really, what a lot of people are using it for is find out, did you already have the infection? So a couple other comparisons about the SARS-CoV-2, COVID-19 versus influenza that we didn't cover before. We talked a little bit about transmission and how it can go through the air. And both with influenza and SARS, it can be that droplet that can be spread through the air. Airborne flu, we think of as having more airborne transmission. Fomite, meaning there's on the surface of something. Perhaps someone has coughed on a table that you're next to, and you wipe your hand across the table accidentally, and could you get it that way? Yeah, you probably could. So that's a fomite when we talk about that. The infectivity, SARS is considered more infectious than the influenza. And even, I'm sure you've heard in the news recently, there are some new variants that we're starting to see in the US that are even more infectious than what we currently are dealing with. Okay. So more infectious than the flu. And we have at least a couple that we're seeing in America so far that are even more infectious than the current one we're dealing with. Incubation, in other words, how long does it take from the time you get exposed to when you get the disease? So looking at influenza, that's 1 to 4 days. Incubation on COVID-19, 2 to 14 days. So maybe a little longer on the incubation period. Severity, real similar on what we're seeing with influenza, and that people we've known in the past are older folks who are upwards 75 or so. A lot of times would get they talk about the old man's gosh, I can't think exactly Steve, maybe you can remember how we phrased that, but
old man's friend.
Old man's friend. Thank you. I was going to
Yeah.
say, yeah, the old man's friend. So in other words, these really old folks, a lot of times would be taken out by influenza. So, but that over 65 on the flu, immunosuppressed, pregnant, morbid obesity, COPD, CAD, chronic kidney disease, being in the nursing home, native heritage, all those we've known for a long time. A lot of that's very similar in COVID, but along with that comes the diabetes, the cancer. So there's all these other diseases really seems to be impacting particularly the vascular system, anything around the vascular system, whether it's the coronary artery disease or the chronic kidney disease or the diabetes, all those, the hypertension, all those are around the vascular system, really seem to be placing people at a higher risk for a rocky course. Signs and symptoms, some of these are real similar. Myalgias, the cough, the congestion, the shortness of breath, hypoxia, the viral pneumonia, growls, which are sounds we hear with the stethoscope on the lungs, and that no sore throat. Again, that's kind of strange, isn't it? That you have all these other things, but not as much sore throat. Patients with the flu, a lot of muscle aches, cough, congestion, sore throat, fatigue. And then looking at the fatality and that increase of fatality compared to the influenza. Really, really striking there. So that's why, when people would say at the beginning of this epidemic, oh, it's just a bad cold, or oh, it's just the same as the flu, it's really not. We have had a lot more people dying of this than we ever did from the flu so far. We've had some bad flu seasons before, but this is pretty remarkable what's happened with COVID. Questions on this graph? Okay, I'm going to move on. So interpreting the test results and what would a clinician be thinking about what they might tell their patient. So if your patient has a 50% chance of having COVID-19, and when I say that, I'm saying you're guesstimating right now. The patient walks through the door, they feel feverish, maybe they got a cough. I've got a 50-50 chance maybe this patient's going to have the disease. And you test 100 people just like her, you would catch 42 of the people with COVID-19, but you'd miss 8 people who do have COVID-19 but test negative. So we call that the pretest probability of 50%, and we can kind of see what that looks like. 42% would test positive and have COVID, 8% have COVID but would have a negative test result. So as we go forward, look what happens if we think patient walks in with a pretest probability of 20%. In other words, he doesn't look too sick, got a cough, but I don't know, he doesn't seem all that sick. So we're going to test those people. 17% will have a COVID-19 and test positive. Remember, it's a really good positive, so they really do probably have it. 3% will be COVID negative on the test, but actually have COVID. Okay. And then look what happens if we think this patient has a pretest probability of 80%. So in other words, the patient walks in, fever, cough, myalgias, maybe the fever is 102. They've got a friend that was sitting right next to them a couple of days ago that's got COVID. They've got, almost probable 80% probability in my mind that patient's going to have COVID. Then we do the test. If we test 100 people, we're going to find about 67% of those will have COVID-19 and a positive test. But 13% starts to get really higher about who's going to test negative. Those are the ones I want to call out to you that we got to be really careful about. Because if we end up telling that person, you got a negative test, so you don't have COVID, that's really the wrong answer. It may be that the test just didn't catch it. And those are the ones we got to be really careful about, is when we're pretty sure they've got COVID. It even brings up the question of, should we even be doing the test? And the answer is yeah. But again, if we get a negative test, I'm going to be real suspicious that that person probably has a false negative result. Questions about that before we move on? I just wanted to kind of walk through what different scenarios look like.
If you had someone who was in that 80% category and you got a negative test, would you suggest retesting, and at what point?
That's a great question, Cheryl, and I appreciate that. I'd probably tell them to go to the health department and get a good viral test rather than the RNA test, and let's really see what it looks like. I'd also tell them I still think you ought to be in isolation. I think you ought to stay away from people until this all goes away. Does that make sense? Good question, but I don't think I'd do another BD Veritor test.
Okay. Okay.
Okay. Other questions about this? So bottom line here, a positive test is conclusive. A false negative test may occur in up to 3 to 13%, depending on the presentation, the way they present to us. Okay. We've got a little, a website that they can go to and play with a probability calculator if they wish. We're going to move on down to the Swiss cheese model. And many of you have been in quality improvement for several years. And so many of you will be familiar with the Swiss cheese model. And what we talk about is, if you were to slice Swiss cheese, a lot of those holes line up, right? As it goes through the cheese, those holes kind of line up. And so when you're thinking about harm to your patient on the right side, see the patient standing there with a mask on over on the right side, and we see those viral particles on the left side, and they're trying to get through all those holes of the Swiss cheese, and they're going to hit some of the holes, and sometimes they're not going to be able to hit through the hole. It's going to hit the cheese instead of the hole. So starting with physical distance, staying home if sick, wearing masks, hand hygiene, using cough etiquette, and notice down below all those, that's personal responsibilities. In other words, I've got a personal responsibility to make sure I'm doing those things. Keeping going as we go there, if crowded, limit your time. Fast and sensitive testing and tracing can catch people and take them out of the community. Making sure we're using good ventilation outdoors, air filtrations on the airplanes help. Government messaging helps a little bit. A lot of people don't trust the government, but it does help others. And financial support that's trying to be provided during this time. Quarantining and isolation, and then the vaccines. And so those are the shared responsibilities that it takes both the person and as well as the healthcare system and other organizations to implement. But when we look through this, all those slices we're trying to create barriers so that patients don't get sick. And each intervention or each layer of that cheese has imperfections or holes that it could get through. But multiple layers improve our probability of success. Any questions about the Swiss cheese model?
And I just wanted to mention that we are making this diagram into a poster. I think it's going to get done. I don't know how quickly, but Christy's got this now to be able to let you all take this in and give it to the practice. It's a strong visual that will help reinforce a lot of the things that we're bringing to them in the practice.
Thanks, Chuck, for reminding me about that. And I'm real excited about them having posters like that. I like having posters of these like this in my own exam rooms for my patients, because they sit there for sometimes, 5 or 10 minutes before I walk in. They could really ponder this. All right, let's move on. Let's talk about the diagnosis and management of COVID-19, and what we're going to be talking to our clinicians about. So thinking about the kind of stages you might think: asymptomatic or pre-symptomatic stage, the mild illness stage, a moderate illness stage, when it gets severe illness, and critical illness. And then we're talking about the features, the testing that needs to be done or has already been done sometimes, the isolation that's required, proposed disease pathogenesis, and potential treatment and management considerations. And so in the asymptomatic, they may have a positive test but not have any symptoms. The testing would be screening tests if the patient has known exposure or diagnostic testing that's done. Do they need to be isolated if they have the disease? Absolutely. Are there what's going on with the viral replication? So this proposed disease pathogenesis, and that they're starting to produce viral particles in their body that can potentially make them worse and worse. And then in terms of potential treatment, there's not really any potential treatment other than maybe a Tylenol if they get a little bit of mild myalgia or anything for someone who's asymptomatic. In other words, they really don't have anything to speak of. There's not really much there, but we all are going to want them to be monitored for symptoms. Going back on up, for people with mild illness, for mild symptoms, they've got a fever or a cough or a change in their taste or smell. But they are not really short of breath. They don't really have much else going on. The diagnostic testing is important. On each one of these, it's going to be important. That we do want them isolated because they can still spread it. Even if you've got mild symptoms, they could still be spreading it without even feeling that bad. We know that the viral replication is going on. It's quite high with someone who's got mild symptoms. Is there any therapy that could be added or potential treatment? Excuse me. Antiviral therapy is not really in this category in general because it's very mild, and antibody therapy is going to be useful in some people. So in other words, if I have a 75-year-old who has diabetes and that person has, some of these early mild stages, I may be sending them to get the antibody therapy, the monoclonal antibody therapy, because I'm hopeful that it doesn't get any worse than this in my older patients. In a 25-year-old or a 30-year-old, I'm not going to be thinking about the antibody therapy. Does that make sense? As we go through, that person we're going to want to clinically monitor and make sure that they get any type of supportive care. So let's go up to the moderate illness. So this is where someone actually has some clinical, I was talking about RALS earlier, RALES. It's something I hear with my stethoscope. So it's clinical or radiographic evidence. So that would, I look at a chest x-ray and I see some haziness in the lungs, or their oxygen saturation. It's still high above 94%, but they've got some of these other moderate illness signs. The diagnostic testing, yep, obviously, again, we're doing that on everybody. The isolation, yep, got to be done on everybody. One of the things on that viral replication, over time, and you kind of see what happens with moderate severe illness and critical illness, the viral replication's not as much as a factor as the inflammation that's actually starting up. And so we see this inflammatory response of the body to this disease that really gets to be the problem. And so particularly in my patients, again, who are having some clinical changes, I'm going to be wanting to think about that antiviral therapy. There are some antiviral therapies currently. They're not very plentiful outside of the hospital, unfortunately. But the antibody therapy is now becoming more available outside of the hospital. So infusion centers is where we're giving that. So if I can get a patient to a hospital infusion center or an outpatient infusion center to get that antibody therapy. And for the practice facilitators on the line, that may be something that you could really help the clinicians nail down, is where in their community is the monoclonal antibody therapy being given. I know that in Tulsa, I had trouble early on finding it, and now it's becoming more plentiful. So like St. John's Infusion Center, it just announced last week that they are doing the infusions. So I think as more and more infusion centers and hospitals are making it available as an outpatient, we maybe see better outcomes on our older folks getting it started earlier. So clinical monitoring if patient is hospitalized and at high risk for deterioration, possibly that remdesivir, and that's that antiviral therapy that we're talking about up here in this area that is really, for the most part, I haven't seen it available as an outpatient yet. Steve, have you seen remdesivir available as an outpatient?
No, Brent, I have not.
Yeah, I haven't either.
I've only seen that given as an inpatient setting.
Right, same here. Okay. The people with severe illness, these are the ones that are critical. Oxygen saturation's dropping. You know, we're seeing it in the 92, 93, maybe less than even that. Their respiratory rate, so they're breathing upwards of 30 times a minute, so they're really short of breath. And we see lung infiltrates in maybe 50% of the lungs on the X-ray. On their testing, again, we've tested them already. We've got them in isolation. We know that this inflammatory component is really high. These are the people that do need to be in the hospital, and they need to be getting that antiviral therapy in the hospital. They need to be getting the antibody therapy and anti-inflammatory therapies in the hospital. And then the critical illness, you know, we've seen this so often. So these people, I had a lady that I saw on Friday who had been in the hospital for 2.5 weeks. She's in her late 60s, if I remember right. Spent 2.5 weeks in her hospital. Her husband had it too. And so they both shared it together, but she was the one that had the really, you know, she could have died being that sick. Had respiratory failure and as other organ issues. So same things here as we go through, and that critical care and specific therapy is going to be really important in those folks. One of the things also just to call out, dexamethasone. I've had patients ask me about, can you send me a prescription for dexamethasone? And dexamethasone is not recommended if people are not in this area, in this stage. And actually, there's possibility that you could make it worse using dexamethasone too early as opposed to better. Okay, I'm going to stop real quick and see if there's any questions about this section. Is that helpful on kind of the progression of the disease and where some of these therapies are useful?
Dr. Beasley, I had a question on when we talked about finding in the community the places for antibody therapy infusions. Is this an actual referral or is it a recommendation?
It is an actual referral. It is recommended nationally that under certain conditions, someone would get that antibody therapy, but it is a referral that would have to be made to the infusion center. So referral, you at least have to have privileges at an infusion center to send your patient there if it's not a referral. So in other words, if a physician or clinician or a practitioner has a relationship with let's say the hospital has an infusion center, they'll be able to send the patient there to get the monoclonal antibody therapy. If they don't, they may have to refer the patient to the site. Does that make sense? Yeah.
Yeah. In Oklahoma City, I know at OU Medical Center how we do it is there's a form you fill out. You fax it, interestingly, to OU Medical Center's pharmacy. They review it to make sure it meets the criteria. You sign off on it. And then it's actually sent to our family medicine resident team, who's overseen by a faculty, who then admit the patient over to O'Donoghue, which is a rehab center on our campus, an old rehab center. It's now kind of used multi-purpose, and they do an infusion under supervision of some staff in that setting. There is a arthritis center in Oklahoma City that you can go online, download their forms, and submit the information very similarly, and then they'll contact and provide infusion if they think it's appropriate and they have medicine available. I know, and it may be true in other places, there's a hospital way down in Atoka. Why I know that is because we were on a conference call with them a couple weeks ago, and they've been doing it too. They've had people as far away as Dallas drive up to Atoka to get a antibody infusion. So they'll take referrals from anyone if they've got the medicine and availability. So there are places around it. I don't know the best way to go about finding the infusion capabilities. There may be a site now online that you can do that. I'm trying to remember what it is now, but there may be an online site to find other places that have that available.
Excellent. Good. Maybe we could get that site.
I'll see if I can find it.
Super. Thank you. Okay, let's move on to the quarantine and isolation guidelines. So just in terms of definitions, quarantine keeps someone who might have been exposed to the virus away from others. In other words, they don't necessarily have the disease. They just know that they've been around someone that has. Isolation keeps someone who's infected with the virus away from others, even in their own home. So in other words, you want to be in a room by yourself and maybe someone slides you the food at the outside of the door for you to get after they run away. People should quarantine if they've been within 6 feet of someone who has COVID-19 for 15 minutes or more. It's that effective, just 15 minutes of exposure. And then staying home for 14 days after the last contact with a person with COVID-19, watching for fever, cough, short of breath, or symptoms. If possible, staying away from others, especially people who are at higher risk for getting very sick from COVID-19. And that is the end of this section. We're going to look, let me see if I can pull it up real quick. We're going to go through and look at our catch-up practice self-assessment. And some of you may have questions about this or thoughts. What we've done, we've outlined just as you're used to looking at the goals, including quality of care, the financial security, the joy in practice, the healthy community on the left. When we see those different objectives, so screening for diabetes and heart disease.
Hey, Brett.
Hold it. I got the wrong one pulled up.
Yeah, I think
Sorry
so.
about that.
I may have done that to you. I hope not, but let me
I may have done it to myself looking when I pulled it up there, Chuck.
That's the one we got too, and I was looking at it and I was thinking these physicians are gonna really
So let me go digging.
While you're digging, I'm going to go on to the immunization guide while you're digging that out, okay? So we're also going to talk to our clinicians about immunizing older adults while we're at it, because one of the things we want to do is call to their attention. Yeah, we've got COVID right now, and yes, we've got COVID vaccinations right now, but there's a lot of vaccines that we need to be talking about. And Chuck, this one's coming up without any pictures on it on my screen. Sorry about that.
Well, we're going to have, so you've got to get to another meeting, right? Don't you have a 4 o'clock?
I do.
So how about if we hold on these other two things for later
Okay,
this week? If you're gonna have time again on Thursday,
okay.
so that we have the current copies of all this. Don't know why you're not able to see that. Weird.
Okay, that
I'll,
is weird.
yeah, we'll chase this other thing down. Make sure that you've got the current copies on all this stuff.
Okay, Chuck, and I'll join you all later this week and we'll talk further. Thank you.
Very good.
Thank you so much.
Okay, bye-bye.
Nice review, Brent. All right, thanks, everybody. Just so you know, where this guide came from is Dr. Beasley spent a lot of time digging out the research material this time. Normally, what it is, we wind up going to another entity and they wind up doing all the research. But in this one, Dr. Beasley did and put together a big slide deck. He put together a guide, put it over to Dan Duffy. Dan worked on it. We've had a clinician panel that included Doug Grevitz and several others like Aaron Windowbow, and you got in Tulsa. He was on the front page of the Tulsa World today. And as the former epidemiologist in the state, but that group has been pounding out what is the evidence for a month or two now, along with Tim and Steve. And so when we finally got through, then we sent it over to ALOSA, and it was really their job just to organize it and to make it pretty. And they have done a phenomenal job, and they did it very quick. So we'd love to have any kind of feedback that you have. But in this case, this is a guy that Dr. Beasley has known from day one of really understanding how all this is going to work. Tim's been so instrumental because of his background, and then having people like Aaron Windowbow and Doug Grevitz. I've just been in awe listening to them of the discussions that have been going on. So anyway, hopefully you're getting a lot out of this, and I'm sure you're going to be hearing it 2 or 3 more times at least in the AD meetings with all your practices. You all will be sick of this thing. Oh, no, you won't. But you'll definitely be informed on this in a very short order. So I will track down what's going on with that, the immunization guide, and the other one that I got to find out what happened, where is the self-assessment document. I'll track that down for you too. Okay. Any other questions, Cheryl?
I was just gonna say, thank you for helping us arrange this and to everyone involved in the AD project. And it's always been one of my favorite part of our programs in person, but even by Zoom like this, it's very effective. And please convey to your practices that just taking that guide and looking through it is not the same thing as having a meeting like this, where you have a person you can ask questions of and who will go through it step by step. It makes it a lot more meaningful for them.
Great. And I'll get the recording over to you, get to the link to you here later on today or tomorrow, Cheryl.
Sounds good. Thank you.